Welcome to Black Health Matters. I'm your host, Darryl Armistead. This is a Howard University Hospital transplant support group session led by Dr. Clive Callender, who is a noted transplant surgeon and professor of surgery at Howard University College of Medicine. Let's join today's session in progress.
I received
Um, the two interesting articles in the Washington Post this Monday. One was on the fact that choking is extremely common in people over 65, and it is actually three-quarters of the people who die from choking are over 65, and they say that it is the one age for which you have more deaths from choking than any other. And they caution uh, people over 65 about taking time to eat your food, to have a lot of liquids when you eat, and you use small portions of food rather than large portions, and not to laugh or joke while you're eating. Um, it's something to think about because as you get older, you have less saliva and you have less muscle control, so it's easier to choke. Any comments or questions about this choking article, which I think is pretty important for our group to keep in mind? Uh, we already know about falls, which is very common a cause for death for people over 65. And now we haven't talked about choking before, so I thought we ought to do that. We'd uh, remind you about taking care when you eat and that and knowing what to do if you choke and uh, how to do the Heimlich maneuver and uh, how to help others. Uh, they do talk about anti-choking devices, but they did not favor any of them. But they did mention that uh, hitting on the back or the Heimlich maneuver are uh, things that you can do if somebody is choking around you.
Uh, yes,
Uh,
Dr. Callender. Oh, go ahead.
yeah, I was just going to say it's not exactly choking, but I have aspiration way too often. Just a little bit of moisture will probably go down my lung, and it feels like I'm choking, but it's not exactly. I have to look out for that.
Yes. I just heard you say that when you get older, you have less saliva. And I here lately, I noticed when I'm talking, my mouth really gets dry. So I guess that's part of it.
It is.
I wondered why. Yeah.
Yeah.
I don't usually have any problem with food because I love liquids. So I'm always drinking. I drink more than I eat, really. But when I'm speaking, lots of times I get dry and I have to lick my lips and to keep from
Okay.
messing up.
Any other comments about joking and experiences you've had?
Choking, um, part of choking, it seems like muscular because I think my father's throat muscles became weak and he couldn't swallow well.
Yeah, that's the other aspect of as you get older, the throat muscles get weaker, and so uh, that's one of the reasons why you have to be careful while you're eating. Okay, the second article that I thought was important to talk about, we've talked about microplastics and contamination, but we haven't talked much about PFASs. which is a abbreviation for polyfluoro substances, which are the forever chemicals that we talked about a couple of years ago about the non-stick uh, pots and pans that have these forever chemicals, and once you get them, it's hard to get rid of them. And uh, also, they mentioned the foods that also have, I guess, clams and oysters, or the shellfish that they talk about. But uh, uh, toilet paper and paper towels and so many things that we use have these forever chemicals, PFAs as they call them. And it's something that we need to be aware of. So we've talked about the microplastics, and they probably know a little bit more about the forever chemicals than they do about microplastics. And they actually have a blood test for PFAs if there's any question about whether or not. But almost everyone that uses paper towels, toilet paper, and these stick-free pots and pans has PFAs in their blood, and they are associated with the same kind of complications that microplastics are, which are uh, uh, arteriosclerosis, cancer, and other issues. So it's just to make you aware of the fact that yes, there are uh, issues with PFAs, and you should just be aware of them. Any comments or questions about this? This is an article in the Washington Post this Monday that is a interesting issue.
Does that mean we should get rid of all of our nonstick cookware?
Kind of late for that because you've been using it all this time.
Oh, so since it's late, you don't have to do anything about it.
Well, if there's a concern, you can always get a PFA level, PFAS level. They mentioned that you can get a PFSA blood test to find out whether you are contaminated. If the level is above a certain level, above 20, then they think it's concern. But it's so widespread that they think that most of us already contaminated, and so they suggest the same common things. They say fast foods are likely to be associated with it. Uh, Joyce, you had your hand up.
Yes, what do you do if you are contaminated with the PFAs?
Well, if you go get a blood test and find out if you have a, then after that, they recommend that you then avoid fast foods, and they have a medication called cholestyramine that and the high fiber diet are the two issues that they recommend if you have a high blood level for PFAS. But those are the two things they recommend. The cholestyramine is the only drug that they mention specifically because that's its main purpose, and then the other is a high fiber diet.
Thank you.
Okay, I just wanted to share those things because I think we haven't talked about PFAs in a couple of years now, and I thought we should be reminded that that situation is still there, and the choking issue that we talked about. Okay, John, I guess we can go to the 20 plus articles that you've identified. Welcome back, by the way.
Thanks.
You want to tell us about your experience while you were away?
Okay, yeah, I was in Dominica. It's a Eastern Caribbean island, kind of small, um, north of Barbados. And we had 13 divers, scuba divers. This is a diving trip. And the coral was beautiful. The water was really, really good. The water temperature wasn't super warm like I'd seen in some other places. Um, like in last year, we went to Grenada, and it was so hot. I mean, it was like 85 degrees at the bottom. But this this water temperature was pretty constant at 84, and you wouldn't believe that 1 degree of temperature could make a difference. But when it gets warm like that, you see a lot of bleaching. The coral bleaches out and it expels the algae that gives it color. So it looks white. The coral looks white, and the temperature's not corrected, then the coral die and fish die and we die. So uh, we have to be careful with global warming. It just reinforces what we've been hearing about global warming. But it was a beautiful trip. Good food. A lot. I think I gained 4 pounds eating breakfast, lunch, and dinner every day. So I have to get back in the pool and lose some of this weight I put on. So thanks for asking.
Okay, this is an article about something we know well about what's going to happen when they cut out the Medicaid in many states, and also when they decrease Medicare. And so millions of patients will lose insurance, and uh, how can doctors help? And that's a good question. And one of the things you can do is to try to take advantage of what you have right now, because we know that Donald Trump is committed to eliminating anything associated with uh, uh, Obamacare, as he calls it. He wants to eliminate everything that has to do with that. And so one of the things we can do is to make sure that if you have insurance now, to get all of the tests that you can get while you can get them, and the things that are appropriate. Uh, because most of those things will take place next year. And so while you got them, this is the time to take advantage of your health insurance. Of course, the stress of recognizing that you've got a administration that is focusing itself on decreasing health insurance uh, makes you should make you more sensitive about doing what you can while you can, and to schedule all of the mammograms, colonoscopies, all of the blood work you need to have as soon as you can this year, because next year there's no telling what kind of situation will occur and how much more money you'll have to spend for out-of-pocket costs. Uh, Trying to find resources using social workers becomes very important to try to do all you can to keep what you have. I think that those are the most important things we can do. One of the nice things about DC so far is that if you're a DC resident, you have Medicaid. That may not be the case in Maryland, but it's the case in DC now. What will happen next year remains to be seen. Any comments about this article? It's going to affect uh, many people under 65, over 65. We're not sure the extent to which Medicare will be affected by it. Medicaid, we know it will be. Okay, no comments, but okay. This is a very important issue. And I think it's very important to do what you can this year to get whatever work you need to be done, get it done before 2026. Okay, let's go to the next article, please. This is an interesting article that suggests that a lot of cancer can be related to the chronology of sleep disruptions and nighttime light exposure. This is something that many of us aren't familiar with. That you could go to sleep with the TV on, and on that the light from the TV can there's evidence that that can affect your cancer risk as well. Light emitted from TVs, computer screens, and smartphones decrease the melatonin production, and this, based upon studies over 100,000 participants, indicated that Elan, which is the artificial light at night, increases the likelihood to have cancer. So if you at night got your TV screen off and your computer screens and your smartphones off so that you don't have this as a situation. Uh, Regular physical activity helps. And uh, John, you had a question.
Yeah. Does you talk about the artificial light while you're sleeping? Is this just coming in through your eyes, or is it through your skin,
Through your
or
skin, right? Through your body, right? This is what the research is suggesting, man. So that this is a component, and when they've done studies on, as you saw, thousands of patients, it begins to make you think that when you go to bed at night, turn the TV off, and that there's some evidence that the light emitted by the computer, the TV screens, and smartphones can be a cause of cancer. That's what this study is suggesting.
okay?
Kind of scary. Betty
Very.
Bailout?
Um, it doesn't have anything to do with just regular light bulbs, does it?
No, it's talking particularly about the TV screen and the
The-
computer screens.
okay, okay.
Well,
I,
most of us, when we go to sleep, we turn off the lights, but I guess maybe some people do sleep with the lights on, but they are not talking about that. They're talking about the TV screen, the computer screens, and the smartphone.
one of my buddies was a astrophysicist, and he told me, like, I don't know, maybe 10 years ago, that his wife uses a sleep mask uh, because it helped her to sleep, blocking the light that comes in. So I've been using a sleep mask for several years now, and it enables me to go to sleep easier because it blocks. Even if you have a window open at night and it's dark, there's still light coming in. So, uh, and then if I'm gonna wake up after sunrise, it really helps that way too. Sleep mask, covers your eyes.
Okay. Any other comment? If not, let's go to the next article. Now, this is an interesting article that says that sesame oil, and they emphasize unheated sesame oil, uh, has been associated with better blood sugar control in women who have metabolic function associated liver disease. Remember, there was, for some time there was no treatment for this, but now We do have some medications that are effective for this, but sesame oil, non-heated, apparently, used in salads or cooked meals, significantly uh, suppresses the inflammatory cytokines that are associated with progression of uh, MASLD. Um, I don't know how many of you use sesame oil or not, but it's an interesting observation. This is a observation that was not made in this country, as I recall, but it's an observation that is in Iran. That's where it was, yeah. So whether it's functional here or not remains to be seen, but it's food for thought. Okay, we'll miss you, Darryl, but thanks for being here and have a great concert.
Thank you.
Any comments about sesame oil? Okay, we can say for once in a lifetime, Darryl was speechless.
I'm sorry, I just don't know anything about sesame oil.
How about that? Something that John doesn't know about? Wow. Darryl. Okay, well, we finally found something that you didn't know anything about. Okay. All right, well, let's go to the next article. Now, this is an interesting article because when you have diabetes, peripheral artery disease is a common complication, as uh, I guess, as was mentioned from one of our who shared with us today that she has peripheral artery disease and a diabetic foot ulcer. And this article says that with semaglutide, which is the GLP-1 drug that people now are using, is associated with fewer uh, uh, peripheral artery disease complications and foot ulcers than the other anti-diabetes medications. And this is something, as we know, diabetes is associated with many complications and peripheral vascular disease and foot ulcers and loss of limbs is something that is something that is a complication that diabetics deal with all the time. And so to have information that this is less commonly associated when you take this drug in preference to the other diabetes medications is a new finding that may be a benefit down the road. Any comments about this interesting article? Because most of us are not on the GLP drugs. We're on the metformin and the other drugs, which are great for the diabetes, but aren't quite as good as preventing the peripheral artery complications. Again, this is work done outside of the United States.
Dr. Callender, my husband, as you know, he is a diabetic, but I noticed that his doctor, well, he kind of asked her to take him off of metformin because it did a little more to his bowels than he felt he needed. But she has him on 2 GLP-1 drugs. So maybe that is helping him to not have that problem. Because his sister was also a diabetic and she ended up having amputation.
Okay.
She
Thank you for
passed.
sharing.
Mhm.
Thank you for sharing. Okay, as we this is a relatively new finding, so all right, if there are no other questions, let's go to the next article. Now, hormonal therapy is something postmenopausal women take to eliminate some of the side effects of menopause. And one of the things that happens is they actually have a concern about becoming obese. And often weight loss is actually desirable, but this uh, when you use this GLP drug, uh, this decreases, this increases the weight that you lose. I don't know how many people who've uh, been concerned about this, but anyway, this is to identify that with these some GLP drugs that who are diabetic, that weight loss can be dealt with appropriately. I don't know that this is a concern. Any of you have this as an issue who take postmenopausal hormone therapy? So it's not a common issue, but it's something that people who are postmenopausal who have side effects and they take hormonal uh, treatment are are aware of. Apparently, this group is not uh, not concerned about this as a complication of postmenopausal hormone therapy. Okay, let's go to the next article then. Now, we talked a lot about GLP drugs and the fact that muscle loss and sarcopenia is associated. And in that kind of situation, the recommendation is that you eat more protein, and a higher protein intake eliminates the muscle wasting that occurs with the GLP-1 drugs. This has been constant as a concern for people on GLP-1 drugs is that they have protein loss and muscle loss, particularly if they're not exercising appropriately and not taking any enough protein. So this is an article that points out that you can overcome that by exercise and by taking in more protein in your diet, which is important. Okay. Any comments about that? Of course, we don't have many people who are on GLP-1 drugs yet, but down the road, that will probably be an issue. Okay, let's go to the next article, please. Now, this is a problem that we've had in recent literature, suggesting that people are using illegally marketing products of kratom, which is a way of getting high on products that aren't so-called illegal, but these actually are considered unsafe, and they're concerned that people will get addicted to these products because they may sell them at places that are not ordinarily used at the smoke shops, and we have many of the smoke shops increasing now, gas stations and corner stores. So they want you to be aware that these products are not safe and to not be tricked into taking any of these products at smoke shops. I don't know anybody who's involved, but you may have known of places where they sell these different products. But the FDA is letting you know that they are not safe and they're considered illegal. I don't think that many of us are involved with that, but it's something that I thought we should just share. Okay, no comments. Let's go to the next article. Now, this is a study that says we now have in the making a way of identifying accelerated aging by looking at a single brain MRI, although it does mention that this is not ready for use yet because they've done studies of more than 50,000 brain scans, and they now are able to identify whether there's a discrepancy between your chronological age and your brain's actual age. But this study just came out, and it's not ready for use. But down the road, in a few years, they'll be able to, with one MRI, be able to identify whether or not you have uh, dementia or not. Uh, Joyce?
Yes, when I was going through my thing about my dizziness, I had an MRI done of my brain, and one of the results that they came back with was it is showing signs of aging. And I said, well, thank you very much.
Yeah, well, this study also correlates your age with the your brain age, and but that's not available yet. So the fact that you're aging, you knew pretty much that you were aging because you know how old you are. So that's not a surprise. Just confirms what you already know. But we're getting to the point now in the next 5 years or so where you'll be able to actually make a diagnosis of dementia based upon one MRI, which is not the case now. Betty, Bela?
Yes, well, once they find out that you uh, have dementia or likely will have it, there still is no cure for it. So,
That's correct. And hopefully by that time, we will have a cure for it. Right now, we don't have any treatment for it that will help. So there's no merit to it. But let's hope that within 5 years, we will have treatment for it. John, you had a question?
Yeah, I want to ask Carol if she can share anything about that lady she met at the radiology office that relates to this article. Okay, she's occupied.
No, she was getting an MRI of her brain, but it was just a very personal lady, and she apologized that she couldn't always understand all those forms, and I was saying everybody was in there, and some of the things that they asked on the form were redundant, and she said, "Didn't you just ask me this?" And she said, "Well, you know, I'm getting MRI on my brain." And but she was expressing what everybody was saying about, you know, how you have to fill out all those forms. Have you had? And she said, "Oh, I need to write down my medical history because I can't remember all this stuff, what I've had and what my parents had and all this." But just a very personal lady. But when we have to go into these offices, or the first time you see a doctor and all the forms you have to fill out, there's it does take a while to, do it, but very personal lady, and was very jovial and apologetic for not quite understanding that complete form.
Thank you for sharing, Carol. Okay, let's go to the next article. This is a study that looks at uh, why I can have pain and consider it a 4 out of 10, and you can have same pain and consider it 10 out of 10. And this just looks at the different nerves and it identified that we all differ in our responses to pain. And so one size does not fit all. And we have to be very sensitive to the patient's concern about the pain. If they say it's a level 10, then it's a level 10. And if somebody says it's a level 4, it's a level 4. And we have to deal with them accordingly because one size does not fit all. And we have to be very sensitive to that and recognize that. So if somebody says they have a 10 out of 10, then we need to treat them accordingly. Darryl?
Yeah, this article reminds me of my experience at dealing with dental school student dentists. Everything they did, including just a simple cleaning, seemed to be a pain level of a 10. But when I go to my regular dentist, it's like a pain level of 0.
That's very interesting. I never heard that one before. That's interesting.
Right. So the expertise of the medical provider is very important in your level of pain.
That's very, very interesting. Yeah. Great observation. Thank you for sharing.
I had a quick question. Does Howard still have the dental students
Yes.
able to work on people? Do
Yes,
you
they
know
do.
how to find those services?
No, I do not. But um, I know that the dental school still has them, and I can inquire to find out. But uh, offhand, I do not have that information available.
Because I remember going there. It must have been at least 40 years ago.
Yeah, it's very different now, but they still have dental students who work with patients.
Thanks for that.
Yeah, my mother went there as well to the dental school. They did a lot of work on her mouth. And it was just walk-in at that point, you
Yeah,
know,
it's changed a lot now.
this change.
Yeah.
But I about this article, I kind of have always said that women have a higher tolerance for pain than men. So where we may be a 3, you all are a 6 or a 7.
Thank you for sharing, Betty. Okay. Any other comments about this article?
But how does this deal with the pain relieving? Could and someone that's just really can't tolerate pain, so they give them a drug and it's really too much, just because even if you just look at them, they feel pain. Um, how does this work when you're giving them medication for the pain?
You medicate them according to what they tell you. In other words, if they tell you that the pain is a 10, you treat them that way. And if they tell you it's a 4, then you treat them accordingly. Not for somebody with a 10, they need to get pain medicine that's appropriate to that, whether it's a Dilaudid or morphine or ibuprofen or so if somebody says pain level of 10, then they deserve the most powerful pain medication that they can get to control. And so you give them uh, the medication appropriate to the level of pain that they claim that they're suffering.
So if they're excruciating pain to you and to somebody else it's just like a regular headache, they can get morphine.
Sure, I would if you've got a 10 out of 10, then I would give you the strongest medicine I could. If you have 4 out of 10, I would give you the mildest medication I could.
Dr. Callender, do they ever go by weight?
No, not particularly. I don't go by weight, but I'll go by you're telling me what level of pain you have, and then of course the dose is determined to some extent by weight, but not the type of medication by weight.
Thank you.
Any other comments or questions about this? Let's go to the next article. We have a number of articles that this is one that I included because I thought it was important to have a balance. Here's an article that says plant extracts relieve hand osteoarthritis. I don't know how common it is. Osteoarthritis is common as you age, but hand osteoarthritis is, and they talk about turmeric and other uh, drugs which are effective at reducing pain from osteoarthritis. And the studies, now, of course, this is work in Belgium, not in the United States, but anyway, they did identify that plant extracts actually work. Uh, Turmeric is something that we've long known as a drug that and food that contains turmeric is good for many things, but I had no idea it was also particularly good for hand osteoarthritis. Darryl?
Yeah, I believe that you have to limit turmeric. Not that you can't take it, but if you're on blood thinners, they say don't go overboard with turmeric.
Thanks for sharing that. Okay, good point. But it's sometimes you hear so much about other things, you don't hear much about plant products that actually uh, relieve pain from osteoarthritis, which is hand osteoarthritis, which is something that is very common as you age.
Dr. Callender, I was wondering, were there other plant that had the same
That's
effect?
the only one that they mentioned in this article. Next article, please. It's one of the things that as I teach students, there was a time when we didn't ask a whole lot of sexual health questions, but times have changed so this is an article that talks about the 7 health questions that you should ask. And as I am teaching my students, one of the things that they are reluctant to ask are these 7. And as you go down, you'll see the 7. First is uh, interactions with the patient themselves and to find out actually what is their sexual history. Keep going down. Keep going down. And why they came to see you. The second one is what have they had a history of sexually transmitted infections? The third is how many sexual partners do they have? And so it's not prying. This is just part of a sexual history that you do if you're trying to take care of patients. And then you want to know, in addition to their sexual partners, do they have oral, anal, or vaginal sex? And do they do it for fun or for money or for what are their practices? And then do they use a condom? Do they use or not? That becomes important to ask and for their health. What is their vaccination status? Have they had the vaccine for papillomavirus? The, are they are they pregnant? And how do they prevent pregnancy? And uh, do they have satisfaction when they have sex, or do they have issues? And these are some of the questions that are part and parcel of what your doctor should be asking you when you go to the doctor. And those questions are not being nosy. Those are questions that are essential if somebody's going to take care of you and take care of you well. Darryl, did you want to make a comment about the other herbal remedies?
Yes.
that you put in the
Others are ginger. Turmeric is top of the list. It's most effective. Ginger, uh, boswellia, also known as frankincense, devil's claw, willow bark, green tea, capsaicin, and eucalyptus oil. Let's see. Capsaicin is found in chili peppers.
Thank you very much for sharing, Darryl. Any other comments about the sexual history that is appropriate? I say that because some people might be offended because you ask them these questions about your sexual history. But it's very important if they're going to be able to take care of you properly, that these are the areas that they should be asking you about. And it's not being nosy, it's being appropriately inquisitive.
Dr. Callender, you're the only physician that I ever experienced in my life right after John's first transplant that you actually ask. And I was sort of astounded, but you never did tell me why you asked it. And I was just going, wow, that lasted in my mind because I said I never had a physician, and I guess I never will because I'm getting older, that asked me about the sexual and all that. And I was just saying, wow. So you may be teaching and do doc, but you're the only doctor I ever experienced that actually asked. That's all I have to say. Anybody else had a doctor that asked besides Dr. Callender?
I didn't have, my doctor didn't, this was back at the beginning when I first went into menopause or getting ready to go. He didn't really ask all of those questions, but he, you know, just kind of touched on it. And he was one of those old school doctors too, but he said he didn't recommend taking any medication for it because it was natural. So I had never had estrogen or any of that. He said everything was natural, but he didn't go into those questions. No. And I'm with you, Carol. No one has ever asked.
Well, it's a new day now, and yeah, in the old days, they didn't ask much, but of course, as you have so many issues now that they didn't have before, it becomes very important to ask all of these questions if you're going to get a sexual history about somebody.
I'm gonna
And
have to ask one of my grandchildren or great grandchildren what their doctors say.
yeah, it's been interesting. It'd be interesting to see. But this is what I require of my students. I have I teach I guess freshman and sophomore medical students, and we have a course on professionalism. One of the issues that we talk about is what are if you have a female and they have a pain in the abdomen, what are the questions that you need to ask them? And these are something that I remind them, and in today's practice, this is required of you.
Mhm.
Okay, if no other questions, go to the next article. This is an interesting article because postoperative delirium, which means after surgery you kind of lose your mind, is associated with a higher death rate, and so it implies that if you can prevent this in the first place, this is what you should do: is to prevent postoperative delirium, and by uh, keeping things in place so that they don't develop it. But if they develop it, you should treat it. Uh, Particularly patients who are on steroids who develop uh, psychosis and other such things. It's important to prevent if possible. Darryl,
Is amnesia a part of post-op delirium?
actually, amnesia is part of a side effect of the postoperative phenomenon. because I wouldn't call it a side effect. I mean, if you have anesthesia, you're expected to have amnesia. That's that's almost expected. So I would not consider that as delirium. Most patients who have anesthesia do not remember seeing the doctor after the surgery, but that's a side effect of the anesthetic and is not considered delirium.
Okay. The reason why I mention this, I have a friend who had a heart attack, and he spent a lifetime as a recording engineer. And after his heart attack, he could no longer remember the recording application that he had used for 30 years. Well, not 30 years, but for a long time.
Well, that's true amnesia. I thought you were talking about the amnesia that is associated with the anesthetic, which is short lasting and disappears within minutes to hours and would have nothing to do with incidents that happened before the anesthetic. So the anesthetic gives you amnesia for maybe um, hours, maybe, but not longer than that. Because what you're talking about, it does sound more like a delirium. So what they're suggesting is if you have uh, aged patients or very sick patients, you have to be very sensitive to reduce the delirium risk, because once you have delirium, the risk of mortality and morbidity increases. And so an ounce of prevention is more than worth more than a pound of cure. John Buchanan?
Yes. So when I hear that word, I'm thinking if somebody's going crazy. Delirious, is that the same thing?
Yes, yes.
That
That's an accurate understanding.
that can result from surgery?
It is not uncommon after surgery, particularly in patients who are very sick or very old. And so you have to be sensitive to that and try to prevent it and treat it early. Uh, in our transplant patients, we had probably about a 10 and 20% incidence of psychosis or delirium secondary to the steroids itself.
Mm.
But that was, if treated early, was easily reversible.
So would this be self-reported or would somebody else call?
No, usually no, if you're psychotic, you're not aware of it. We have to be aware of it and sensitive to it. Right. Because you may be seeing things or hearing things that aren't there, and you think they're there, but we know that they aren't. So this is something that we have to be observant of and be conscious of and intervene as quickly as possible.
And that's just the result of being under the anesthetic.
Well, it's a combination of your age and your sickness. Uh, it's more common with older patients.
Mhm.
So we have to be more sensitive to older patients if they're going to be put to sleep.
Thanks.
I remember my experience, Dr. Callender. Um, they asked me about some trinkets that I had on the shelf. And I told them that they were moving, but they weren't.
Yeah. Hmm. Interesting.
You remember that, I think.
Yeah, well, as I said, when you're on steroids, it was not uncommon to have a delirium postoperatively.
I thought it was a Percocet.
Well, it depends. I mean, I was talking about, we're talking about after surgery. Percocet can do that as well. But I was talking about the anesthetic that you get when you put to sleep. But that can be a side effect of Percocet as well.
How come they don't tell you that that's a side effect of Percocet?
I don't know why anybody wouldn't tell you that. Well, probably because it doesn't occur in everybody. It occurs in some people. And so if you look at your PDR and you look at the side effects of all the medications, you probably wouldn't take any of them because they have so many side effects. So that if the doctor doesn't tell you that for example, one of the things that occur with some patients on some medications, they go sleepwalking and they get up and uh, do strange things, and you're not predicting that that's going to happen. We know it's a side effect, but it's not something that we tell you about all of the side effects because you may be too frightened about them. Uh, if there's anything that out of the ordinary that occurs, you should let your doctor know about it. Jochebed,
Yes, sir. Good morning, everybody.
hi, good to see you again.
Is this immediate post-operative reaction or delayed or
Immediate
long?
Immediate
Okay.
post-operative, yeah. It is the hope that you pick it up early so you don't have to deal with it later because there have been concerns that in older patients that when they wake up, they aren't the same mentally as they were when they went to sleep. So it's very important to evaluate the patient early in the postoperative phase and treat them and eliminate that as a possible problem.
Hmm.
But that has been a concern, what you mentioned, has been a concern that some patients after surgery are not the same mentally as they were before the surgery.
Thank you.
Any other comments or concerns? If not, we'll go to the next article. This is something that I'm sure many of you have heard about. The term gaslighting, as you read in this article, is a term that was used because uh, people and doctors as well minimize sometimes the patient's pain or concern or illness, and they don't actually treat them as they should. Not dissimilar to what we talked about with pain, but a patient comes with a concern, whether it's a pain or itching or any disease entity, you have to take it and understand it's real. And just because you cannot find out what caused it does not make it unreal. I mean, I think I did a study in psychology in which we recognize that most of the concerns that patients have are legitimate and real. And because you aren't able to figure it out and understand it, doesn't mean that they are making it up. It just means that you haven't found the problem. And so this article is emphasizing the importance of taking patients' concerns seriously and not minimizing or pretending that because you can't find the answer that you give a excuse that it's mind over matter, when in point of fact it isn't. And this particular patient had unexplained body paralysis, and they said it was anxiety, and it turned out she had a neurological condition which required surgery for cure. And so the term of gaslighting became something that we have to become more uh, understanding of and to recognize that when a patient comes in with symptoms, you have to deal with the symptoms and try to find the cause. And if you can't find it, get some help. But don't say that it's anxiety. And this is something that many patients have had to deal with physicians who, because they couldn't find the answer, they said it was anxiety, when in point of fact, it just meant that they couldn't find the answer. Any comment about this gaslighting phenomenon that physician-patients, doctor-patient relationships have found common?
Dr. Callender, this was common with my